On the 15th of June 2011, the Wessex Health Innovation and Education Cluster hosted a one-day conference to promote and accelerate the use of Telecare and Telehealth in the Wessex region. Invitations went to key decision makers across the trusts and social care organisations, and over 70 people attended. The keynote speakers were Mike Clark, who's working with the King's Fund, Ross Tolcher, CEO of Solent NHS, and Mark Fisher, a consultant in Telecare working in Sussex. In Solent NHS Trust, the use of telehealth in patients with chronic obstructive pulmonary disease has successfully reduced the number of admissions to acute care and has enabled the specialist nurses to focus their attention on the most needy patients. Here are the highlights of the day that demonstrate how telehealth care can be of huge benefit to patients and carers.
There's an interesting challenge to all of us, well, the technologists in the room, as to whether we can get this technology so actually you don't need a field team. It can be posted out to people somehow, or I think it's the Whzan demonstration, they come into the GP and pick it up and just go with it. You wouldn't need the field team then, because that's obviously a fairly significant cost. But this is the important thing for me. You know, telecare is nothing without care. It's primarily care, it's just how do you actually do that care remotely. That's what tele means, remote care.
An example of a local company bringing new products to this market is Solcom, who demonstrated their Whzan system. There is a video of this on the Wessex Telehealthcare website.
Summary and detailed information is available.
The definitions of Telecare and Telehealth at this time, some people have brought those together under the banner of Telehealthcare. There are all sorts of other definitions. There's e-health and m-health for mobile health, but I'm going to stick with Telecare, Telehealth and telemedicine maybe, and just give you some idea of the numbers.
If we believe that telehealth's moment has come, we need to get over this thing that it's innovation and new and different, and mainstream it and embed it in our core practice. And to do that, we need to make sure that the healthcare practitioners and the next generation understand the language, understand the technology, and have the skills to make it a reality. And Skills for Health is exactly that. It's a nationally funded programme. We're working in partnership with the university to deliver telehealth technology skills to the next generation of staff.
What we've done is developed within adult social care a training session for all members of staff, making actually telecare training, and we have a specialist unit compulsory for all staff. Now, before any care package is agreed, we are saying to our social workers, and what have you done? Have you considered telecare? I think it's the main thing for telecare. We're actually having people remain in the community much longer, but it is the family dynamics that are supporting as well. We've managed to bring people out of residential care into the community, being supported by telecare as well.
We also know from our own internal data actually that we have fewer home visits, and my nursing teams estimate that they've been able to reduce the number of visits by about 60 per month to these patients. It doesn't mean that they're sitting idly in their offices doing nothing, of course. What it means is that they're using their time in a more focused and a more sophisticated way to visit the patients who have greatest capacity to gain, rather than just routine visiting.
I've been working on a project which is an integrated project between the Isle of Wight PCT and the Isle of Wight Local Authority. We're putting together an urgent care hub. Part of that will be looking at telehealth and telecare. The urgent care hub is a call centre that's bringing call centre functions together from health and social care. And we've already seen within the local authority that they've been using telehealth to good effect. We can see that there are opportunities in other areas of healthcare, such as maternity.
And then we've got to make sure actually that the rollout of telehealth is not just some interesting add-on that gives us a little bit more information, that it actually adds value, and that we stop doing it the old way and that we have sufficient trust in the system to use the device rather than feeling that every single trend that looks a bit adverse means that somebody's got to redo it all. We've got to believe in what the machines are telling us if they're of the right quality. You absolutely need support from the top to the very bottom of the organisation. At the end of the day, using telehealth, we're asking individuals with long-term conditions to entrust part of their care to measurements taken remotely by machine, and we're asking clinical staff to change their practice based on that information. I think it is important that we recognise the win-win in all of this is making sure that all of the people who have to change get the benefit, and recognising that the currency of benefit does change depending on where you are in the system.
How do you guys see its role in prevention? I don't mean just heart failures and respiratory distress as a lot been discussed, but in long-term problems, for example, diabetic wound healing, chronic wound healing. We've had some dealings with Southampton PCT and we work with them over the years, but how does this fit into that?
First of all, the payback on preventive interventions has a lot longer run rate and it is even harder to measure. But I guess for me, telehealth, the role it has under the second P in the QUIP thing is around secondary prevention and tertiary prevention really. So for COPD patients, for example, if you can spot a trend, then you can prevent an acute deterioration by earlier intervention.
The new technology that in speech therapy that we'd like to look at is a remote web-based interface for delivering speech and language therapy treatments, and in particular the Lee Silverman voice treatment, which is a treatment specifically targeted to those who have Parkinson's disease, and it aims to improve their communication.
More recently, working with our partners in Solent NHS Trust, trying to increase the use of it in patients with COPD.
I think for the client group that I work with, who are people with progressive neurological conditions, I think it allows greater access to those individuals. They're often very frail and unable to get to outpatient appointments, and if I could monitor them closely in their homes, then it would allow me greater accessibility to those clients.
For the healthcare system, for the NHS, I believe it will be cost effective, even though to some people there's not sufficient evidence to show that yet.
The other thing it enables us to do is change the way we manage healthcare, taking more care out of the acute setting, out of hospital and into the community. And I think that will enable us, with the challenges we face around the finances, hopefully to meet the growing demand for healthcare with the more limited budgets that we have got.
I believe absolutely that it's time to move away from this perception that telehealth is something sort of new and innovative and slightly different to mainstreaming it. We're also looking at it in the context of continence services, palliative care, and also the uptake of video conferencing. We provide healthcare to a number of prisons across the patch, and some of you will know how very difficult it is to take prisoners into hospital for consultation and to provide the right level of clinical care for patients who become acutely unwell. I think there's a real potential for us to be using the video conferencing facility for that. That suggests that those of us who have an open mind and a willingness to go to the next phase could deliver some huge benefits for patients and for the NHS as a whole. But the implementation needs to be thoughtful. We don't just want to add this on as something else and another piece of work that somebody does. It has to be a substitution that adds value for patients as well as organisations. Success of doing that is predicated on behaviour changes and pathway changes, and it stretches beyond single organisations and it stretches across health and social care. Finally, the win-win scenario is where not only is there a patient benefit, but actually there is a system benefit in terms of savings. And I just take you back to my little run through the sums so far. Just because we haven't spent the money in one environment doesn't mean that we're not spending it in another environment, and if we don't manage the care pathways properly, we risk actually putting costs up because we're still spending money in one place and spending a little bit more money in another place.
The NHS is facing one of the biggest challenges in its history, with increasing demand, higher expectations by consumers, and with demographical changes that will impact on the capacity of the NHS to respond in the traditional ways. Social care services are in a similar position. The NHS and local government are starting to develop telehealth and telecare capacity on a small scale, and a body of evidence is being built up to support organisations to implement these services. Issues around data integration, information management, identifying best solutions, and reorganising services and staff to new ways of working are some of the challenges that are being highlighted to the HIEC as causing blockages. The HIEC programme is busy supporting trusts with their plans for the expansion of telehealth and telecare, facilitating network sessions to help overcome the obstacles to adopting telehealth, producing regular information and weekly bulletins, see www.wessexhiecpartnership.org.uk, and building opportunities for service development. We want to build on everyone's interests and promote success. If you are considering doing any work in this area, please get in contact with the programme on Wessex HIEC at sotton.ac.uk.